have, traditionally, when we conclude a workshop like this, one of us has been assigned the task of taking notes over the course of the day to kind of do some reflections on what we've heard and the takeaways. I'm struck by the fact that there are a number of other experts in this room that haven't spoken today at all. And we'll have time as a center to really work through the things that we heard. Most everybody on our staff was here today, so we're going to have that opportunity to chew on this for a while, to really absorb the tremendous amount of information that we've been given today. But what I'd like to do for the next few minutes, the next 10 or 15 minutes, is to give an opportunity for some of you that haven't had a chance to speak. I'd like to hear, I'm going to pick on a few of you. I think Rich Morgan, I'd like for you to comment if you would, and Rick Butin, Dr. Cordell, if you'd like to say a few words. Diane, I think I'd like to hear from you too. We haven't heard much about geriatric issues, but I know they're a tremendous source for many of us who have parents who live with chronic pain on a daily basis. My mother of 88 years being one of those who's comes from that generation where and although she's German, she lived with my dad for a good number of 52 years, and he's the Irish stoic that we heard about earlier today, as are most of her children. And she's not a complainer, but she says a lot of rosaries. So what I'd like to do is finish with one takeaway that those of you that I called on have from what you heard today that you think might benefit us in our continued work in this important space. So take a few minutes if you want to. Those of you that are maybe ready to comment, Richard, go ahead, please. This is Rick Morgan.
Thank you.
Introduce yourself, please.
I'm Rich Morgan. I have to say, I enjoyed this a lot more than I thought I was going to. What a great day it was. Thanks. And I don't work in a cesspool. I'm at work in private practice. In 1985, I went up to do a critical care fellowship, and I talked him into doing 6 months of pain management, which was unheard of in 1985. And I learned how to do celiac plexus blocks on cancer patients with pancreatic cancer without the benefit of x-ray and some other things as an anesthesiologist. And in 1992, I met for the first time and went to a conference and heard Dr. Portnoy speak. And I learned about new ways of treating pain other than using needles. So I've been treating chronic pain since 1985, and I got my hospice and palliative care boards 10 years ago. In the first year they offered them in 1998 or 2008. So I do about 30% of my time in hospice and palliative care and about 70% of my time in chronic pain management. I write opioid prescriptions every day and have done so since about 1994. And I still have questions about opioids every day. And it's not so much that I'm worried about it. I really am not worried about that I'm doing it the wrong way. But am I doing the right thing? They're not perfect drugs. And I think that we all know, Nora, I really appreciate what you said, because those are, I feel it. When some of the things I have to do or I feel I'm doing, I don't think are in the best interest of the doctor-patient relationship, but I feel that I have to do them, limiting how much I prescribe. And I make phone calls at the end of every day trying to justify some of the doses of medicines that we use. I'm going to finish it up, but I think we're in the dark days of pain. I think if we asked Dr. Bonica the question of what is pain, he would still say the same thing he did in the 1950s. If you ask 100 people, you get 100 different answers. Because pain is really about suffering, right? It's not just about physical pain, it's a suffering. I've heard that over and over again, and it can't just be treated as a biological problem. I have 2 artificial joints, and I suffered with a lot of pain before, and I talk about the blessing of those joints. If I had those joints 50 years ago, I wouldn't be here today because I couldn't probably walk here. And think about that, and stents in the heart, and things that we do. I think 50 years from now, we'll look back at these dark days of pain and wonder how we ever managed with these crude tools like opioids.
Thanks, Rich. Who's next? Rick Butin? Dr. Butin. And others of you, please feel free to, I just picked on a few to get us started here.
I'm Rick Butin. I'm an internist and palliative care doctor at Truman Medical Center, teach at UMKC, associate professor there. And in many ways, all the comments have straddled what I do every day also. I see patients in the general internal medicine clinics at Truman. Truman is the ultimate safety net hospital in the city. And happens to actually appreciate Medicaid patients due to what up till this year was the disproportionate share advantage that a place like Truman has with Medicaid patients. Medicaid actually would pay more to us than they would to most providers. Anyway, almost every day now I have a new patient in my clinic, and 9 out of 10 of them are about pain, because they've lost their insurance. The pain clinics do not take people without insurance, and many do not take Medicaid. And so they come to me and they say, I need you to continue the same pain medicine I was getting elsewhere. It is very difficult, and what you had said about time has been sort of lost in the discussion about fear of retaliation from the DEA, because my big problem is time. A brand new patient who wants to have pain medicine as well as their diabetes and other things takes a minimum of 45 minutes. And I have 4 patients per hour scheduled. So I'm at the end of every morning. My clinic ends about 1:30, my morning clinic. So time is the big issue here. We're trying to do the right thing. I have the skills. I'm board certified in palliative care. I run the palliative care team, consult team at Truman. I have the skills, I just don't have the time. So.
Thanks, Rick. Diane, you ready?
Can people hear me without a microphone?
Yeah, there's one coming, right here. Introduce yourself, please.
I'm Diane Clark. I'm with the Landon Center on Aging at KU Medical Center. I have worked in the healthcare field in an administrative capacity almost 35 years. And so if we're going to defer to people who have age-specific knowledge, we need to ask Linda Redford about caring for older adults. She's a nurse. But I will say this, that my first job in healthcare was to work for Dick Block at the Cancer Hotline. And if you ever wonder if your life experiences come to a place where they all connect, it has for me, in that I am almost 4 years into being the caregiver for a person who I love very much. And I would say that sometimes I write an obit in my head for her. And I read obituaries a lot. You never see somebody say that someone died after a long, wimpy battle against cancer. And I would say, during these 4 years, my role as a patient representative, which I did in the hospital side for a number of years, has served us well, because I have dropped the F-bomb a few times on all kinds of people during this journey. And the thing that I've heard today that I want to know more about is, how are you engaging insurance companies in this discussion? Because policymakers and caregivers and patients and all of us can come together and talk about this, but who holds the power? And that whole experience of going to the pharmacy to say, well, we can't give it to you now. You just had this filled. Or if you want it, it'll cost you $8,000 before you walk out the door. It's crazy. It's crazy. And insurance does seem to carry all the power right now. And I want us to fight them. Some people want to fight the DEA. I'm really pissed off at the insurance companies. And so that's my takeaway for today.
Anybody here from Blue Cross or United want to respond to that? Humana? Aetna? Linda?
Hi.
Tell us who you are. Go.
In terms of what Diane said, too, I think, too, in dealing with the elderly, another thing that we're running into is the aging of the population, is that your alternatives for dealing with pain get less and less in terms of our pharmacological approaches, because Certainly, aspirin is not high on the list of things that you want to use for pain in an older person. Ibuprofen is now being recognized as having all sorts of adverse effects, particularly on the heart. And opioids aren't great either, but they've actually been kind of the one we could go to with the least adverse effects. But we know that they also have the downsides. One of the things, I think we need to, as a group, move toward also is this whole notion of what else is out there, getting the evidence behind what else is effective. I agree, acupuncture's been around for a long, long time, and the fact that it has been used successfully in a lot of places. I've used acupuncture for chronic back pain. It was wonderful. I have used it for some other things that didn't work as well. So, but I think we have to look at all these alternatives. I think we have to look at nutrition. I think we have to look at the physical therapists. I think we have to look at all these other people, chiropractors, massage therapists, all of the people that bring something else to the table, because these do work in some cases, not every case, but we need to put it all together. And I would agree that I lived for about 8 years or so with chronic pain from needing a knee replacement, and I really love knee replacements. So some of the artificial joints have made all the difference in the world that I don't have chronic pain now. So, I think we need to look at what all's out there. I think we need to be promoting this, and I think we really need to be pushing those insurance companies to pay for these other things, which is the only thing that's holding it back in many cases.
Thank you. Other folks, I think we just lost Judy and Kathy, so go ahead, in the back. Oh, Katie left too? No, shoot.
My name is Rayanne Kingsley, and I'm a nurse practitioner at Children's Mercy. And this has been very helpful. And in the global perspective and in the grassroots efforts, I think much of this goes across all populations. And I don't want to be the voice, but at least a voice also for children, because chronic pain is not something that is just an adult issue or an elderly issue. We see kids of all ages every day that also have this, and they have many, many years ahead of them. And much of our treatment also is not a one-size-fits-all. And kids do have many similar issues. They have many of the same mu receptors, but some of their issues are very unique. And I just don't want to overlook that there is a global one-way approach. And as with malignant pain and non-malignant pain and low back pain, there may be different approaches. There may be different approaches in kids as well.
Thank you. I was particularly struck by the words chosen by the young man in the video that Lynn shared, that when he was reflecting on 60 more years of this, he said, that's not very, and then he kind of paused and he used the word promising. I thought, God, what kind of person would, it's the strength that you would have to say it's promising as opposed to, how tragic or how, depressing or whatever, but just to reframe it for himself in terms of promising as though. Clay?
Clay Anderson again. I was inspired last night, and particularly today again. Most of us are involved on the micro level, have been, will be, helping individual patients get what they need. And I agree with Dr. Morgan that these are going to be a difficult 3 to 10 years when changes are not going to happen fast enough. We've got to kind of turn the pendulum, swinging back the other direction, kind of fix both of the problems that Dr. Waylo and others have spoken about. But I think what inspired me from Dr. Waylo, Lynn, others, is that we can do something ourselves on the macro level too, targeting the little bit of energy we have left after hard days at work, walking with people who are suffering and helping them any way we can to do something like help with the documentary, work in the political process, take the strategy and help move it forward in ways that we're going to find out we can help out later. And maybe I didn't appreciate as much before today the role we can play if we want to with that bigger process. And the time is now, because things are going to keep getting worse year by year if we don't all get involved now. And I don't want it to take 10 years. I'd rather only have it to take, 2 or 3 or 4 years before all of our practices are improved instead of worse with the scrutiny and the bureaucracy and the policies that make it harder for us to care for our patients.
Anybody else? Go ahead.
Ask on that he said about getting involved. I'm a nurse practitioner. I'm very involved at work. I'm very involved institutionally in my own community. But what else besides this is out there? Like, do I just walk up to my legislator? I mean, what do I do to get involved? I live in Olathe, Kansas. What do I do?
Somebody, Ann, Myra, you want to take? Lynn?
Are you on social media? Are you tracking Bob? Are you a follower of Bob and other people in the field? I mean, we are Bob, myself, and dozens of other people, Jeffrey Fuden. There are people out there advocating and trying to make a difference, but I believe social media is going to be a major vehicle for actually the people in pain more so than those of us who are clinicians. But we want to hear their voice and then reinforce it. So we can be the echo chamber for the people that are suffering either with the diseases of addiction or with chronic pain, but we can support them. And so I think social media is a day-to-day sort of involvement that you can get engaged with. Make sure you know your congressman, make sure you know your state legislators, and stay tuned to the policy so that you can write letters. These are real things that'll have a real impact, and everyone knows all of our elected officials like to hear from their constituents. And then if you get 2 or 3 other people to do the same thing, you may have a major impact.
I'd like to comment. Were you there last night? Okay. At the end of the evening, John Carney, the person at the podium now, articulated several things that we were asking people to do. One of those was to, and this would apply whether you're a healthcare professional or a lay person, a person living with chronic pain or not. If you know someone who lives with chronic pain, talk with them about it and tell them that you care about that. The American Academy of Pain Management, you heard Amy Goldstein talking about SPAN, which stands for the State Pain Policy Action Network, or some version thereof, but it's SPAN for the American Academy of Pain Management. They have a wonderful, wonderful service that they alert those involved about legislative activity in their state. This national pain strategy that we have been hoping and praying for about a decade now was just posted in the Federal Register. We showed the link today. Look at that and see, share your comments, share your thoughts. Your opinion as an advanced practice nurse is critically important. There are opportunities for you to be involved in PAINS, which is the Centers project that really is the underpinning for this today. We have been trying very, very hard to organize those living with chronic pain in Kansas City and our safety net providers. What I've become convinced of today is that we need to broaden our net here. We need to throw a wider net. One of PAIN's goals, there were 3 goals. One was to get a national pain population health strategy in place. We now have that. The second was to create, support, and network community and state initiatives. We've called them Relieving Pain In. So Relieving Pain in Kansas City, there's a project at Texas A&M and in the state of Texas. There are other efforts, Michigan, New Hampshire, other places where people are talking about trying to get organized. So if you have the energy and the time and the interest, there are opportunities for you to be directly involved. I want to comment on the number of comments that have been made today about insurance. One of the 6 strategic areas in the National Pain Strategy Report is about reimbursement. All of you who have said the very profound things you've said need to go to that section and comment that until this is realigned, it will not change. Now, PAINS is having a national meeting at the end of June for those who've been involved in our project to come together in Washington, D.C., hear from those of us who have worked on this plan to make sure that people know what the plan contains. Primarily, I've said I want people to begin to see themselves in the context of this pain. I want people to start saying, what can I do, given this articulated framework? And or, what can my organization do? Where do we fit in this plan? PAINS has, as part of our strategic plan for this year, scheduled in the second half of the year to host a meeting with third-party payers. And we've talked to lots of different people involved in this, those who live with pain, those who care for them, those who do research about it, and everybody has said, absolutely, get it organized, and I will be there. So we've had conversation with United Healthcare, with Aetna Coventry, it is now, with the Blues. So there are so many ways that everybody in this room can get involved in this movement. And you must. I mean, it will not change without really a tidal wave of demand for a cultural transformation in the way pain is perceived, and how those who live with pain are perceived, and how those who care for them are perceived. How it is treated. We can no longer just be writing scripts and sending people to specialists to get nerve blocks and steroid injections. We have got to offer people many, many more options. And how perceived, judged, and treated. So I think that really covers it. And I think I've probably been on my soapbox so long
Well, and
today,
I don't know
John,
if you
that
heard.
people are tired
You're
of it.
from
but,
Olathe, right? Myra's there next week talking on pain. So make
I'm
sure you're at the
speaking
meeting.
to the nurses at Olathe Hospital Tuesday afternoon about chronic pain. Oh, and everyone is more than welcome. If you live with chronic pain, we would be thrilled to have you regularly attend our citizen leader meetings.
Lynn?
Yes, you can go to painsproject.org, pains with an S, painsproject.org.
Okay, my parting shot before introducing Dr. Dubin. He'll give us the farewell, and thank you again for hosting today, and Mark, you as well, for a terrific job of greeting us with this beautiful venue. One of the things that I hope to be able to do is to come to a better understanding of how I need to share a philosophy that I've had for many, many years as working in the hospice profession, is there but for the grace of God go I. And I've heard that over and over again today. And I get the liberal compassion piece that Keith talked about this morning, and I think I probably gravitate towards that just naturally. But there's also that conservative skepticism that I experience even in my own family with my very conservative brothers and sisters. And there is a difference, and we all came from the same womb, and still in a family have very, very different perspectives on this. So maybe my homework is with my brother in Texas, who doesn't remember that he actually grew up in Kansas anymore because he's a Texan, and spend some time with him to find out where he is on this issue. And maybe I might be able to hear him a little differently after today than I have before. So with that, I'll turn it over to Bruce. Thank you.
Thanks, John. Reflections and kind of wrap up, and I do have some reflections to share from last night and from some of the things that you all have heard today. And I guess it starts with one of my favorite plays, and that's Death of a Salesman. And in it, there's a scene as Willie Loman is being laid to rest for his finality. A eulogy is being offered, and the statement is made, attention must be paid. Attention must be paid to this man. Attention must be paid. And I guess that gives me some chance to reflect on what it is that we've talked about beginning last evening and sooner than that for many of you involved in the center and some of the conversation that went on here today. So attention must be paid, and it started last evening with a discussion of the political level, and attention must be paid there. We heard Dr. Welu talk to us about political theater. There was a time in America when discussion of pain was a personal thing in the 30s, 40s, maybe 50s between a physician, a healthcare provider, and a patient. And the physicians had enough time to pay attention to his patient. But that's before the courts got involved, much of that centering around money, disability payment, and the idea about who should make the kinds of decisions around the complex situations around pain. Certainly the IOM study, if nothing else, told us that appropriate treatment is not being received by 100 million people or more in terms of pain. Attention needs to be paid to that, and it shouldn't just be paid at a political level, but if we're going to pay attention to it, we need to get involved in the politics of pain. So where does that mean? Where does that mean when you leave today? Well, attention needs to be paid at the state, at the local level, and at the national level. That means phone calls to your congressman, phone calls to your senators, letters, email, social media. But attention does need to be paid, just like in the case of that common man, Willie Loman. And it needs to be paid at all levels of the political spectrum. Good or bad, it is reality. And politics is very much involved with pain. Attention must be paid at the physician level. Dr. Gomez, you commented about that earlier, and I agree with you. It's not so much the fear of criminal charges by the DEA, it's the fear of having that state investigation and someone walking into your office, grabbing charts and labeling you as just someone who's out to make a quick buck, providing Percodan to the population. That's a big fear by physicians. And whether it's real or just perceived, that perception is reality. And it does limit the interaction between the way physicians interact with patients. Attention needs to be paid by the very nature in which we deliver health care, especially to patients in chronic pain. You've heard about time. Well, I've got to see 4 patients an hour. What's worse on top of that is, by the way, I have to look at a computer and enter everything you're saying into this electronic medical record. So even my face-to-face contact with you, because I want to be an empathetic physician, is deterred because I've got this stupid machine that I've got to use between me and you. So even that facial expression and that feeling that we can communicate with each other just by looking at each other is being diminished, and attention needs to be paid at that. Better training for physicians. I train doctors. I've trained hundreds of them over the years. I will tell you, in the area of chronic pain, it is not very good. Medical school has been under 4 years for over a century, and everybody has their favorite topic. And I'll tell you right now, chronic pain ain't one of them, okay? It's not. And we need to do a better job with that. We need to do better jobs with creating the standards to make sure that that training occurs, and a better job with real simulation exercises so that medical students and residents and fellows can have better training with that. Attention needs to be paid for that. And we need to do a better job of role modeling as part of medical education, because we send young men and women out on hospital rotations as students and residents, and they sometimes get paired up with doctor, oh, that's just another pain pill seeker in here claiming they have chronic pain so they can get more Percodan. Attention needs to be paid for that. The insurance level came up. Attention must be paid to that. We cannot utilize a cookbook approach to a problem that isn't even clearly defined, and how we even define pain. Cookbooks don't work, but that requires time. And we're dealing with a system that's broken, that really cares a lot about cost savings, where decisions are made by people who never have face-to-face contact with a patient. Attention needs to be paid at a societal level. Now, a lot of us are here today and we understand the meaning behind chronic pain. But when you turn on a TV set and when you hear a reference about opioids and pain medications, and that this superstar or that superstar is really in rehab, that conflicts with the ability of the public to understand what chronic pain and pain medication is all about. In order to solve the problems of chronic pain, we have to deal with the problems of society. We do live in a culture where a variety of drugs of abuse are utilized for solving some of societal, well, it doesn't solve it, for dealing with some of society's ills. And that conflicts at times with the ability or with the fears of politicians in rendering the appropriate care that needs to come forward to people who have a pain. So attention needs to be paid to societal problems as well, to get jobs for people, to get people to work, to get people stop seeking inappropriate medications when they don't need it, and the ability to receive appropriate medications when they need it. At a scientific level, we need to enhance the funding for studies and best practices in the treatment of chronic pain. It needs to happen, but that's going to be a social movement. Someone isn't going to sit together one day because there's always competing interests. We've got to do a better job of doing better research in this whole biopsychosocial model of dealing with chronic pain, of helping patients, of working with patients in their day-to-day lives. We've got to stop it so that patients don't walk into a doctor's office or walk into a pharmacy and get labeled as a drug addict merely because they're in pain and are asking for the medication that they need. My wife goes occasionally to a physician to get a cough medication when she has an upper respiratory infection, and they give her this much cough medicine with codeine because you might be a drug seeker. We've got to stop that, and attention needs to be paid to that. One of my favorite older movies is a movie called Terms of Endearment. I don't know if many of you remember it or not. It starred Deborah Winger, Shirley MacLaine, and Jack Nicholson as a drunk astronaut, go figure. In it, Deborah Winger, who's in hospital for treatment of cancer, needs her pain medication. And the nurse says, "You've got 5 more minutes." She can't get it until 5 o'clock. It's only 5:02. And there's this great scene in the movie where Shirley MacLaine runs out to the nursing station, jumping up and down, screaming, "It's 5 o'clock, it's 5 o'clock." Now, 5 minutes later, she can get her relief. Totally absurd. It happens today. That story is repeated still today. It's an old movie. Attention must be paid. So the question is, as we all leave here today, where are you going to pay attention? Just some thoughts and reflections. The stories need to be told, and then they need to be told to a whole multitude of folks. We mentioned politicians. They need to be told to doctors. They need to be told to state medical boards. It needs to be told to the DEA. It needs to be told to the deans of medical schools. It needs to be told to hospital CEOs. It needs to be told over and over and over again. And it needs to be done in convincing stories, your stories, and if not your stories, the stories of your friends, because we all know those stories. We need to share those stories, and we need to get that message out. The other way that attention can be paid is you can work with groups like the Center for Practical Bioethics. Attention can be paid through the center. We can use your help. The center can use your help in many ways. That's the way attention can be paid for everyone. With that, I'd like to thank you all for visiting our campus today and taking part in this presentation. Thank you.